what about, and maybe this wasn't looked at previously, but this is near and dear to me. Did you ever consider the medications that people were taking too? And how might we be able to reduce some at risk medications for them or get them off of certain medications that might increase their risk of falls, for example, or various issues that you can just imagine what somebody who's going through PT or post surgery might have complications with?
Yeah, for sure. I was always a less is more type of surgeon. We know certain things like patients that take opioids preoperatively or chronically on pain medications tend to do worse. They have higher complication rates. They have poorer outcomes. Even things like tramadol that we think maybe are benign, the literature has shown are not as benign as we think they are. If patients take them preoperatively, they're more likely to be on them chronically postoperatively, which we want to avoid with all the movement to reduce opioid usage. And so we learned that, hey, if we can identify those patients and we can put them on a protocol or a program to try to reduce or eliminate their use of those medications preoperatively, they tend to do better postoperatively. We went back and forth for a long time with, gabapentin and some of these other medications. Do they work? Do they not work? But we know they have side effects. They didn't seem to, if you really looked at the literature carefully, have a positive impact on recovery. So we kind of eliminated those from our multimodal, P management strategies. Adding things like tranexamic acid, which was really revolutionary for joint replacements and cutting our transfusion rates essentially to zero, and all the positives that come with that. So, yeah, pharmacological interventions had a huge impact on that transition to more value-based care. Intra-articular injection cocktails, things like that to cut down on postoperative pain medications. All those things from a pharmacological standpoint played a huge role.